Hello and welcome to Critical Care MD. My name is Dr. Vikas Koparapu and I am a physician in pulmonary and critical care medicine. My goal with Critical Care MD lectures is to help you understand fundamental concepts of critical care medicine so that you are better prepared for your ICU rotation and you are more comfortable in caring for the critically ill patients. Today's topic is respiratory failure. I have divided this topic into two parts. In the first part, we will talk about the physiology, we'll talk about the causes and approach to workup and diagnosis. In part 2, we will talk about the management. Let's start with definition. Respiratory failure has two types of definition. There is a concept based definition and there is a criteria based definition. Let's start with the first. Respiratory failure is simply the inability of the lungs to meet metabolic demands of the body. Lungs have two important roles. One is to provide oxygen, two is to remove carbon dioxide. If the lungs fail to meet either of these requirements, then it is respiratory failure. While this definition helps us understand respiratory failure, it is not very useful when it comes to diagnosing respiratory failure. That brings us to criteria-based diagnosis. There are two types of respiratory failure. One is hypoxemic respiratory failure defined as oxygen level or PaO2 level of less than 60 millimeter mercury. Second is hypercapnic respiratory failure defined as PaCO2 level of more than 45 millimeter mercury. In my opinion, a third entity should also be included under respiratory failure, and that is respiratory distress. Even with normal oxygen and carbon dioxide level, if the patient is tachypnic, is uncomfortable using accessory muscles of respiration, then if left untreated, it's only a matter of time before they develop florid respiratory failure with abnormal O2 and CO2 level. Now, generally, respiratory distress is associated with abnormalities in either O2 or CO2, but there are certain disease states like profound circulatory shock or metabolic acidosis where the patient is trying to compensate for metabolic acidosis by breathing fast, which can lead to respiratory distress. Let's go into the details. We will start with hypercapnic respiratory failure. I have organized this topic into the following headings. First, we will start with physiology, talk about general mechanisms of hypercapnia, and see how these mechanisms evolve in a couple of common conditions associated with hypercapnia. Then we will move on to clinical approach. We will start with clinical features. Then we will look at how to interpret CO2 level on a blood gas. And finally, we will discuss the etiology or differential diagnosis for hypercapnia. The most important concept to know is that carbon dioxide removal depends on alveolar ventilation. Let's understand this. Consider this tube and balloon model of the lung where the yellow part of the tube is depicting all the airways, starting from the upper airways all the way down into the terminal bronchioles, basically all the airways where there is no gas exchange happening. The green part of the airways represents respiratory bronchioles and the balloon represents all the alveoli. So the green part is where the gas exchange is happening. Now the air going in and out of this system has to go through two different compartments. The first part is all the airways where there is no gas exchange happening, and that constitutes dead space ventilation. The second part is where there is gas exchange happening, and that constitutes alveolar ventilation. So anything that decreases alveolar ventilation leads to increase in the CO2 levels. Broadly, there are two different mechanisms that can lead to decreased minute ventilation. Decreased alveolar ventilation. The first is decreased minute ventilation. So anytime there is decreased air being breathed in, that leads to decreased air circulating through the alveolar ventilation. So conditions where minute ventilation can go down include: one is decreased respiratory rate, two is decreased tidal volume. Second is increased dead space fraction. Let's talk about dead space. As we saw, dead space is basically all the areas of the lung where there is airflow but there is no gas exchange. There's two types of dead space. The anatomic dead space is all the upper and lower airways until the terminal bronchioles, which are not participating in gas exchange. Second is alveolar dead space. These are basically the alveoli where there is airflow happening but there is no gas exchange happening due to an underlying disease process. Physiologic dead space is basically a combination of alveolar and anatomic dead space. Let's understand alveolar dead space. Consider this example. We have two alveoli, and these structures here represent the pulmonary vasculature. Deoxygenated blood, which will always be depicted in blue in my talks, is going to flow through the pulmonary arteries, and there is gas exchange happening at the pulmonary alveolar capillary membrane, and oxygenated blood, which will always be depicted in red in my talks, is going to leave through the pulmonary veins. Now, there are two disease processes where this gas exchange may be impaired. One is any interstitial process like pulmonary edema or interstitial lung disease, where there is no gas exchange due to interstitial problems. Second is pulmonary vascular disease like pulmonary embolism or pulmonary hypertension, where there is decreased blood flow through this pulmonary vasculature, leading to impaired gas exchange. Usually when there is a pulmonary vascular disease process, there is compensatory increase in ventilation through the rest of the normal alveoli. So they usually make up for it, and it's rare to see hypercapnia in settings of pulmonary vascular disease. Another useful concept to know is that any decrease in tidal volume leads to increase in dead space fraction. Consider this example. Again, tube and balloon model of the lung. The patient is inhaling 1 liter of air, and 250 cc is going through the anatomic dead space, and the remaining 750 cc is circulating through the alveoli for gas exchange. Let's say this patient takes only 500 cc of air instead of 1000 cc. Let's see what's happening. The anatomic dead space is fixed, so 250 cc of air will have to pass through the anatomic dead space, and the remaining 250 cc is available for gas exchange. Let's take a closer look at the numbers here. When the tidal volume goes down by 50%, the dead space ventilation is not affected. However, the alveolar ventilation has gone down by significant amount. So this is a very important concept to know, because this will help you understand why patients with COPD develop hypercapnia. Again, the concept is any decrease in tidal volume leads to increase in dead space fraction. Other way of saying it is decrease in alveolar ventilation. Now let's see what happens to tidal volume in COPD. Two important concepts to understand are gas trapping and hyperinflation. So patients with obstructive lung disease, especially patients with COPD, have difficulty exhaling the air due to airway narrowing or airway obstruction. So what happens is, over time, as the disease process is worsening, they can't fully empty their lungs. So at the end of exhalation, some air gets left behind. And as the disease process continues to get worse, the trapped air increases in volume, and over time, lungs become hyperinflated. So there are certain changes that the thorax undergoes to accommodate these hyperinflated lungs. For example, there is flattening of the diaphragms. The chest wall becomes barrel shaped. So there are some changes to accommodate the expanding lungs. But this remodeling can only happen to a certain extent. After that, there is not much room for the lungs to expand, meaning the tidal volume starts to go down. Now take this example. The upstroke here is inhalation and the downstroke is exhalation. With normal airways, a person is able to completely exhale the air, and there is enough time before the next breath starts. However, in a patient with COPD, they need more time to exhale. So as the disease process worsens, or during exacerbations where they're breathing fast, they don't have enough time to fully exhale or fully empty the lungs. Let's say this patient inhales 500 cc tidal volume, but only has time to exhale 400 cc. Means there is about 100 cc left behind, and when they take the next breath, they have 600 cc at the end of inspiration, and when they exhale, they only empty around 400 cc because they don't have enough time, meaning the next time when they take a breath, they have 700 cc left inside the lungs. Now, if this were to be a balloon, it expands and expands until it pops or bursts. But with lungs, what happens is they are surrounded by a semi-rigid chest wall. So after a certain point, they can't expand any longer when patient takes a breath in. That means their tidal volume progressively starts to decline as the disease process worsens. Another common condition where you may see hypercapnia is CHF exacerbation, and the cause here is multifactorial. There can be airway edema, which can mimic obstructive lung disease. There can be interstitial edema, which can lead to increased dead space fraction. And due to these two conditions, there can be respiratory muscle fatigue because they are working against increased airway resistance and they are working to expand wet and stiff lungs. When respiratory muscles get fatigued, tidal volume can potentially be compromised. The main symptoms of hypercapnia are shortness of breath and altered mentation. Signs are usually related to the underlying disease. For example, when it occurs in the context of COPD exacerbation, you may notice wheezing, tachypnea, use of accessory muscles of respiration. When it occurs in the context of opioid overdose, for example, you may see shallow breathing, decreased respiratory rate. It also may be associated with hypoxemia. None of these signs or symptoms are specific for hypercapnia, and the presentation can be sometimes subtle. So, whenever you have any reason to suspect hypercapnia, especially in a patient with risk factors like COPD, morbid obesity, opioid overdose, or opioid abuse history, always get a blood gas. One frequently asked question is, do we always need to get an ABG or is VBG enough? Now, for for the most part, VBG is as good as ABG or almost as good as ABG as long as you're looking at pH and PaCO2. A couple of caveats to keep in mind. VBG is less reliable in states of global hypoperfusion like circulatory shock conditions, particularly cardiogenic shock, or when there is regional hypoperfusion. For example, let's say there is arterial stenosis of the blood vessels going into the right hand. You don't want to get blood gas from that area because it's going to be unreliable. Second is, whenever available, always go for a central venous blood sample compared to a peripheral venous sample. Once you identify hypercapnia, it is important to differentiate acute from chronic hypercapnia. Now, carbon dioxide combines with water and forms carbonic acid that dissociates into protons. So whenever CO2 levels go up, the acid content in the blood goes up. In the acute state, there's not enough time for the kidneys to compensate for this, but in a chronic state, there is renal compensation. So the features of acute hypercapnia are there is respiratory acidosis and pH is usually very low. Bicarbonate doesn't go up much, usually around 1 point increase in bicarbonate for every 10 points rise in carbon dioxide level. Versus chronic hypercapnia where there is metabolic compensation, so pH is going to be well compensated, it will be normal or near normal, and bicarbonate goes up by a much higher degree, like around 3.5 points for every 10 points rise in carbon dioxide level. Once hypercapnia is diagnosed, it is important to look for the causes. Based on what we discussed, the causes of hypercapnia can be organized into one of these three categories. First is decreased respiratory rate, opioid overdose being a common example. Second is decreased tidal volume. Conditions that you may see in ICU presenting with this mechanism include COPD exacerbation and neuromuscular diseases like Guillain-Barré syndrome and myasthenia gravis. Third mechanism is increased dead space fraction, CHF exacerbation being a good example of this. There are several other conditions that can cause acute hypercapnia or acute on chronic hypercapnia. These are listed on the table. In summary, hypercapnia can have a subtle presentation, maintain a high index of suspicion, and get a blood gas whenever in doubt. VBG is acceptable in most cases, but with some caveats as we previously discussed. It is important to differentiate between acute and chronic hypercapnia because acute hypercapnia needs to be treated right away. Once hypercapnia is identified, it is important to look for the causes. Based on the mechanism, it can be one of these three causes as we just saw. Now let's move on to hypoxemic respiratory failure. I have organized this topic into the following headings. We will start with physiology and discuss the mechanisms of hypoxemia. Then we'll move on to the clinical approach, talk about clinical features. We will talk about different measures of hypoxemia. Then we'll talk about the etiology or differential diagnosis for hypoxemia. Finally, we'll go through a case for practice. There are some very important physiologic concepts to understand here, namely the A to A gradient, the VQ mismatch, and shunt. There's also diffusion limitation, which is somewhat less important clinically, but these are some important concepts to remember. Let me start by asking you a question. What do you expect the PaO2 to be in a young, healthy person who has been placed on 100% oxygen, let's say via a non-rebreather mask? Assume the CO2 levels are normal. Here are your options. So what number among these options best matches the expected PaO2 in this individual? Let's discuss about A to A gradient and then we'll come back and answer this question. Now, alveolar capillary membrane is where all the action is happening as far as oxygen uptake is considered. Let's understand the anatomy and physiology of the alveolar capillary membrane. On one side, the membrane is lined by pulmonary epithelium and on the other side by capillary endothelium. Normally, oxygen and carbon dioxide should freely diffuse across this membrane. We're going to use the letter capital A to represent partial pressure of oxygen inside the alveolus. And here is the formula. We basically take the pressure of atmospheric air and multiply it by percentage of oxygen. However, there's more to the formula. As oxygen is being taken up, carbon dioxide is also being dumped into the alveolus. So that takes up space and impacts oxygen uptake. So we have to account for that by including this part into the formula. So you remove PaCO2 divided by R, which is the respiratory quotient. So that's the final formula for the capital A. Let's substitute these with numbers. So the barometric pressure at sea level is 760 millimeters of mercury, of which 47 is moisture, so we remove that, multiplied by percentage of oxygen in room air. So at sea level again it is 21%. Normal PaCO2 is 40 millimeters of mercury divided by respiratory quotient is zero 0.8 at resting state. So if you do the math, this number will be around 100 millimeters of mercury. So the capital A, or the partial pressure of oxygen inside the alveolus at sea level on room air, is 100 millimeters of mercury. The letter small a represents partial pressure of oxygen inside the alveolar capillary. Under ideal situations, all the oxygen inside the alveolus should freely diffuse across the membrane and be in equilibrium with the capillary oxygen. So big A should be equal to small a under ideal situations. However, that's not the case because even in normal lungs, there is regional differences in ventilation and perfusion. The apices of the lungs usually have better ventilation compared to the perfusion, and due to gravity, the basal regions of the lungs have better perfusion compared to ventilation. So there is regional VQ mismatch even in normal lungs. So due to the physiologic VQ mismatch, there is normally a gap between the big A and small a. Not all oxygen from the alveolus diffuses into the capillary. So a rough number for the A to A gradient is 8 to 20, but using the formula h by 4 plus 4 gives you a more accurate estimate of the A to A gradient. Now let's get back to this question. What would be the PaO2 in a person who has been placed on 100% oxygen? Let's say this person is 24 years old. Let's start by calculating the expected A to A gradient. So at 24 with healthy lungs, the expected A to A gradient is 10. Now let's calculate the big A. So that is 760 minus 47 multiplied by percentage of oxygen. So here the patient has been placed on 100% FiO2. So that'll be 100 by 100. Room air again is 21%. So that'll be 21 by 100 if this person was to be on room air. Minus normal PaCO2 is around 40. Respiratory quotient is 0.8. So if you do the math, that number will be 663 millimeters of mercury. That's the partial pressure of oxygen inside the alveolus. Now we know the A to A gradient should be 10, and we know the big A. So you replace the big A with 663 minus small a equals 10. If you rearrange the numbers, the small a will be around 653 millimeters of mercury. So in this person who has been placed on 100% oxygen, if you draw a blood gas, the expected PaO2 should be around 653 millimeters of mercury. So from the options that were given, the closest number was 600. So option D was the right answer. Now, if you have blood gas and you know how much oxygen the patient is on, then you will know, the partial pressure of oxygen, you will know the percentage of oxygen, you will know the CO2, and assume respiratory quotient is 0.8. So you will know the big A and you will know the small a based on the blood gas. So using these numbers, you can actually calculate the A to A gradient for any given patient. And if the A to A gradient is normal, then that means healthy lungs. So for practical purposes, normal A to A gradient means normal lungs, or more precisely, normal alveolar capillary units. When A to A gradient is increased, then we need to look into the causes, the pathological causes that would increase the A to A gradient. Two important concepts to discuss here are, one is VQ mismatch and second is shunt. Let's start with VQ mismatch. So here is an example of normal alveolus. There is deoxygenated blood flowing through the capillaries, gas exchange is happening, and oxygenated blood is leaving. In this example, there is a problem with the airways. Let's say there is a mucus or there is bronchospasm, or for any reason there's a problem with airways impairing the gas that's entering and leaving this alveolus. So here ventilation is compromised, perfusion is okay, but due to that mismatch there is impaired gas exchange. Take the other example where gas flow through the alveolus is okay, but due to pulmonary vascular disease, let's say due to pulmonary embolus, there is decreased flow of the blood through this capillary. So this alveolar capillary unit is not contributing much to oxygenation of the blood. Now, based on this, the causes of VQ mismatch can be organized into these two categories, preserved ventilation, impaired perfusion, and vice versa. Examples of impaired ventilation are obstructive lung disease, emphysema, pulmonary edema, and interstitial lung disease. Examples of impaired perfusion are pulmonary embolism, pulmonary hypertension, and congestive heart failure or heart failure. Next concept is shunt. What is a shunt? It is basically mixing of deoxygenated and oxygenated blood, or in simple terms, mixing of the impure blood and the pure blood. So there's two types of shunt: physiologic or intraparenchymal shunt and extraparenchymal shunt. We'll talk more about these in a minute. Let's understand the circuit of the circulatory system. Tissues, after taking up oxygen, dump the deoxygenated blood into the venous system, or let's say the impure blood into the venous system. That blood goes all the way through the right atrium, right ventricle, pulmonary artery into the lungs, where oxygen is taken up, and that fresh oxygenated blood, or let's say the pure blood, is going into the pulmonary veins, left atrium, left ventricle, aorta, and the rest of the body. The blood that is entering into the veins from the tissues has an oxygen saturation of 70%. After going through the lungs, it is richly saturated with blood, so the blood leaving the lungs is 100% saturated. Normally, this is a one-way circuit. There should not be any connection between the venous side and the arterial side. Let's understand shunt physiology, starting with the intraparenchymal shunt. This is a normal alveolus where deoxygenated blood is being richly saturated with oxygen, and blood returning to the venous side is 100%, has 100% oxygen. Let's say this alveolus has pneumonia, it's filled with pus, so it's not participating in any gas exchange. So the venous blood that's going through this particular alveolus is not carrying any extra oxygen back into the left atrium. So depending on how many alveoli are diseased, the final blood entering the left atrium and ultimately to the rest of the body is going to have an SpO2 somewhere between 70% to 100%. So this is an example of intraparenchymal shunt, where mixing of the pure and impure blood is happening inside the pulmonary parenchyma. Now, what causes intraparenchymal shunting? It's basically any disease process that fills up the alveolus. Common things being common, it can be fluid, pulmonary edema, it can be pus, pneumonia, it can be inflammation, pneumonitis. Now, this is a broad diagnosis. Inflammation can be in the form of aspiration pneumonitis, drug-induced pneumonitis, ARDS, and radiation pneumonitis, and a multitude of things. It can be atelectasis, and less commonly it can be due to diffuse alveolar hemorrhage and other causes. Let's move on to extraparenchymal shunt. So here there are anatomic connections between the venous system and the arterial system. For example, in the lungs there can be pulmonary AV malformations. One example would be hereditary hemorrhagic telangiectasia. Other example would be hepatopulmonary syndrome, where there are connections between venous and arterial system, so the blood bypasses the alveoli and the deoxygenated blood mixes with the oxygenated blood. Second is cardiac causes. So within the heart and the vasculature, there can be connections like ASD, PFO, ventricular septal defect, or patent ductus arteriosus. So when any of these conditions are associated with right to left shunt, the impure blood basically bypasses the lungs, goes into the arterial system, and causes low oxygen levels. Next concept is diffusion limitation. This is basically abnormality of the pulmonary alveolar capillary membrane. It can be destroyed in conditions like emphysema or lost in conditions like lung resection, or it can be damaged due to inflammation and scarring in conditions like interstitial lung disease. Usually the interstitial lung diseases have a lot of physiologic overlap with VQ mismatch and shunt physiology, though there can be impairment due to diffusion limitation as well. So clinically this is somewhat less important, but importantly, the VQ mismatch and shunt physiology are the things we need to understand. So with that understanding, the causes of hypoxemia or low oxygen level in the blood can be categorized into these two compartments, let's say. First is low oxygen with a normal A to A gradient, meaning healthy lungs. So conditions that can cause this are hypoventilation and low partial pressure of oxygen or low fraction of oxygen in the inspired air. For example, in high altitude conditions, there can be low atmospheric pressure and the FiO2 can also be pretty low. So in these situations, even with healthy lungs, there can be low oxygen level in the blood. Second is increased A to A gradient. So whenever you see this, two important issues to consider would be: one is VQ mismatch, two is shunt physiology. Before talking about clinical evaluation, let's understand the difference between hypoxia and hypoxemia. Hypoxia is impaired tissue metabolism due to low oxygen, whereas hypoxemia is simply low level of oxygen in the blood. Hypoxia is a concept. Hypoxemia is a measurement. Just like anemia means low level of hemoglobin, just like hypoglycemia means low blood glucose. So the symptoms of hypoxemia can be varied. Obviously every cell in the body needs oxygen to survive, so there can be multi-system kind of presentation when there is low oxygen level. Typical symptoms are shortness of breath, chest discomfort, anxiety, palpitations, and altered mentation. Signs can be either related to the respiratory distress. So when oxygen levels are low, patients are breathing fast, they're using axillary muscles of respiration. Or sometimes if hypoventilation is the cause of hypoxemia, like let's say in a patient with opioid overdose, you will see signs related to that. And finally, there can be signs related to underlying etiology. Like if the cause of hypoxemia is congestive heart failure, you will see JVD, pedal edema. If it's pneumonia, you may notice fever and crackles on exam. Once you suspect hypoxemia, the immediate next step should be confirmation. Know that oxygen in the blood is carried in two different forms. Majority of it is carried by hemoglobin. There's a small percentage, however, which is carried in the dissolved form. So the first part, the one carried by hemoglobin, is measured in the form of percentage saturation of hemoglobin. Second is measured in the form of partial pressure of oxygen. So in the beginning, we reviewed the criteria for hypoxemia, which is defined as PaO2 level of less than 60 millimeter mercury corresponds to an SpO2 of 90%. There's two ways of measuring low oxygen level. One is using a pulse oximeter and measuring something called SpO2. Second is you can take a blood sample and measure percentage saturation of hemoglobin directly on the blood sample, or can measure the partial pressure of oxygen in the blood sample. Pulse oximeter is generally the initial test of choice as it has several advantages. It is easily available, it is non-invasive, you're not poking the patient for blood draw. It is quick and gives you continuous data. The way a pulse oximeter works is based on the principle called spectrophotometry. It is based on the fact that light at different wavelengths illuminates oxy and deoxygenated hemoglobin. So a pulse oximeter basically sends light through tissue or blood and analyzes the waveforms and give you the percentage oxygen saturation. When we use this technique to measure percentage saturation in a peripheral tissue, we call it SpO2, and when we use it to measure saturation directly on an arterial blood gas sample, we call it SaO2. Pulse oximeter is a very popular device, but there are some caveats to keep in mind. For pulse oximeter to work properly, it has to be able to detect the pulse contour or waveform with dichrotic notch. If it cannot detect the waveform, then the data is not going to be accurate. Think about conditions like malposition of the probe or severe hypoperfusion where pulse oximeter is not able to pick up the waveform. In these situations, the data is not going to be reliable. There are also some hemoglobin abnormalities like carboxyhemoglobin seen in carbon monoxide poisoning or methemoglobin where pulse oximeter data is not going to be reliable. It may show falsely high reading or falsely low reading respectively. Additional conditions that may interfere with pulse oximeter data are listed. Before moving on to diagnostic evaluation of hypoxemia, a word of caution. Take all the numbers we discussed with a grain of salt. For example, we are saying PaO2 level of less than 60 is hypoxemia, right? But that does not always mean hypoxia. For example, take people living at high altitude. They're exposed to chronical low levels of oxygen. Their bodies get used to it, their physiology gets adjusted, and they may not show any signs of distress or signs of impaired tissue metabolism despite their PaO2 level being less than 60. Another example is patients on supplemental oxygen. As we previously saw, if you put somebody on 100% oxygen, their expected PaO2 will be 650. So in this patient, is PaO2 level of 65 normal? Absolutely not. The A to A gradient here is more than 500. That's very abnormal. So take the number with a grain of salt. Always think about the patient when interpreting these numbers. Now let's talk about the causes of hypoxemia. Based on the A to A gradient, you can categorize the causes into one of these two groups. It can be due to decreased oxygen entering into the alveoli. So here the A to A gradient will be normal, meaning the heart and lungs are okay, but there's not much oxygen coming into the alveoli. The second category is the more pathological category, where hypoxemia can be due to either VQ mismatch or shunt. We'll expand more on this in the next slide. Now we are going to summarize all the diagnostic workup for respiratory failure and put it in one slide. The first question when you're evaluating a patient with respiratory failure is the PaCO2 normal or is it elevated? If the PaCO2 is elevated, then broadly there are two causes. One is hypoventilation, which could be from decreased respiratory rate or decreased tidal volume, or it can be from increased dead space fraction. Then we move on to assessing the A to A gradient. If the A to A gradient is normal and the PaO2 is normal, then that's normal state, normal lungs, normal oxygen. If the PaO2 is low with a normal A to A gradient, then it is due to low oxygen coming into the alveoli. If the A to A gradient is abnormal, meaning it is elevated, then the differentials at this point are VQ mismatch and shunt. These are clinically the most important causes. So one feature that can be helpful clinically is that hypoxemia in VQ mismatch tends to be easily corrected with low flow oxygen, usually under 5 liters per minute oxygen, versus in shunt, where typically patients are needing much higher levels of oxygen or sometimes even positive pressure ventilation to correct the hypoxemia. So when you suspect shunt physiology, the main differentials are intraparenchymal and extraparenchymal shunt. So to differentiate between these two, you need to get chest imaging, depending on the situation, either X-ray or CT scan. If you see a lot of ground glass opacities or consolidation, then that indicates an alveolar filling process that contributes to intraparenchymal shunt. If the chest imaging is normal or relatively normal, then you need to think about extraparenchymal shunt. Let's practice with the case. We have a 36-year-old male with history of alcohol abuse. He was admitted for alcohol detoxification, but he was noted to have high oxygen requirement as well that has persisted several days into admission. Patient has a new diagnosis of cirrhosis, and the nurse also noted that whenever the patient lays down or lays flat, the oxygen levels seem to be improving. You're taking over the case and reviewing the data. This is what the blood gas shows: the arterial blood gas, pH of 7.35, PaCO2 of 40, and PaO2 of 45. This was obtained when patient was on 100% oxygen via a non-rebreather mask. You also look at the patient's chest imaging or CT chest, which does not show any significant ground glass opacities or consolidation, so CT scan is relatively normal. Let's review our diagnostic algorithm. Patient's PaCO2 is normal, so we move on to A to A gradient. Here it's highly elevated, it's very abnormal. Then next step is looking at whether the hypoxemia is corrected with low flow oxygen or not. Here patient is needing a lot of supplemental oxygen. He's on 100% oxygen. So at this point we are most likely dealing with a shunt physiology. Then next step is we look at the chest imaging. Here it is essentially normal. So most likely we are dealing with an extraparenchymal shunt. So the next step in evaluating extraparenchymal shunt is we get an echocardiogram with a bubble study. The way a bubble study works is, while we are looking at the heart on the ultrasound, we inject agitated saline with microbubbles through the veins. So those microbubbles initially enter the right atrium, move on to the right ventricle, then they travel down the pulmonary artery into the lungs, where all the bubbles are absorbed and none of them should enter the left side of the heart. So if you're noticing those microbubbles entering the left side of the heart, that is abnormal and that is reported as a positive bubble study. So in this case, you order an echocardiogram and the report says the bubble study is positive, and specifically it says the crossing of the bubbles was noted after 6 or 7 cardiac cycles. So how does this piece of information help us? As we have seen, the extraparenchymal shunting can happen within the lungs in the form of connections between arteries and veins, or it can happen within the heart in the form of ASD or VSD or patent ductus arteriosus. So what is your final diagnosis? What we know is patient has a diagnosis of cirrhosis and he has shunting of blood from arterial to the venous side within the lungs. So what does that make you think of? What condition? The answer is hepatopulmonary syndrome. That concludes today's discussion. I hope you found this video helpful. If you did, please support my channel by clicking on the like and subscribe buttons. Also, share it with someone who you think will benefit from it. Finally, I would love to hear your thoughts. Is there any part of this video that you found particularly helpful? Is there anything I could have added to make this more useful to you? And what topics would you like to see me discuss in the future? Do leave a comment and I will see you in the next video.